first, just an overview of what I'm going to talk to you about today. I understand that the people watching are likely to be a broad audience and include students, clinicians, carers, and the general community. I'm hoping to have tailored this presentation so there's something in it for everyone. I'm going to start by showing you a brief video about trauma, and then I'll talk more about trauma and PTSD. I'm mainly going to focus on the PTSD treatment guidelines as I've been closely involved in their development over the last 3 years. I'll then talk about the current treatment recommendations, both for adults and for kids, and the main changes to those since we did the last major update to the guidelines in 2013. I'll also point you in the direction of resources for clinicians, for people with lived experience of trauma, and also for caregivers, including parents. And at the end, I'll invite your input. We've been doing a consultation around these guidelines, and it would be really helpful to hear from the attendees here today in terms of what kind of resources and what sort of changes you'd like made to the guidelines. So first of all, though, I'm going to show you this brief video.
There are moments in life that test us. They challenge our understanding of the world and our sense of safety. Natural disasters, accidents, violence. These events can come from nowhere, or they may have always been part of our life. Trauma comes in many forms. It affects thousands of Australians every day, people from all walks of life. The ripple effects of trauma impact everyone. After a traumatic event, the world can feel unpredictable and unsafe. For most people, this feeling passes with time, and with support from loved ones, life goes back to normal. But sometimes it's harder to get back on your feet. Fear, sadness, guilt, and anger are all common reactions, but when they continue for too long, they can leave you feeling helpless and exhausted. Distressing memories, images, or sounds may replay over and over in your mind. The effects of trauma start to creep into everyday life, affecting relationships. You may even pull away from important relationships and activities. You may have trouble getting a good night's sleep, and sometimes it can be tempting to reach for alcohol or other drugs. It can feel like you're on a treadmill, not making any progress, and you don't know how to get off. You're left feeling overwhelmed and trapped, and your family and friends feel helpless. But there is a way out. Effective treatments and support are available from professionals who understand trauma. You can get your life back. For information about recovery, visit phoenixaustralia.org.
I hope that was helpful to shed some light on understanding a little bit more about trauma, though I imagine that this audience here knows a significant amount about trauma as it is. I'm going to talk a little bit more now about how we conceptualise trauma and also about traumatic events. So trauma, we know that we use fairly loosely in everyday language. The word trauma literally means to wound, and in the mental health context, it refers to injury or damage to a person's emotional or psychological health and well-being. In the mental health context, traumatic events have a specific meaning. There's two parts to that meaning. There's the idea of the characteristics of the event itself, and then our reactions to it. So not everyone will be affected by the same event in the same way. So there are many different events that can be experienced as traumatic. That might be single isolated events, such as a motor vehicle accident or involvement in a violent crime. Alternatively, traumatic events can be chronic, repeated, and prolonged, such as childhood abuse, family violence, armed conflict, or institutional abuse. A traumatic event might involve a threat to a person's personal sense of integrity. For example, experiences a threat to their sense of self or a feeling of violation. And traumatic events can be experienced directly or indirectly or vicariously. You've probably heard of vicarious trauma or secondary trauma. Among the most common traumatic events for Australians are the sudden death of a loved one, seeing someone badly injured or killed, or unexpectedly seeing a dead body, experiencing family violence or sexual assault, or involvement in a life-threatening car accident or childhood sexual abuse. It's normal to have strong emotional or physical reactions during or immediately following a traumatic event. There's lots of different ways that people can react. Some people might shut down and feel numb. Others might experience distress. There are some fairly common responses to trauma, and you could see that in the video. That's some sense of shame, a sense of guilt, or perhaps some outbursts of anger. So how common is trauma and how common is PTSD? We know that experiencing traumatic events is common. Up to 70 or even 75% of Australians have experienced at least one traumatic event in their lives. Most people report 2 or more traumatic events. And of those people, between 15 and 25% will go on to develop PTSD or post-traumatic stress disorder. Now, while most people exposed to potentially traumatic events experience significant distress in the immediate and the short-term aftermath, most people recover without professional help. Most people don't go on to develop trauma-related mental health conditions such as PTSD, depression, anxiety, or substance use. But in any year, we know that 4.4%, or that's over 1 million Australians, will have PTSD. That makes PTSD Australia's second most prevalent mental health condition. So what other mental health problems can follow trauma? We know, and I've mentioned before, that PTSD isn't the only problem that can arise from trauma. Other common problems include anxiety, depression, loss and grief, alcohol and drug use, and they can occur in any combination. In people who do have PTSD, these extra problems are more likely to occur the longer the PTSD goes on. Many people start using alcohol or drugs as a way of coping with the symptoms of PTSD. Sometimes traumatic events involve a great deal of loss. You might have lost someone you knew or cared about. You might have also lost a sense of safety or a sense of normality or just a sense of trust in the things that you thought you could trust previously. Some people who develop PTSD after a traumatic event have other mental health problems in the past. For those people, a traumatic experience might lead to the reappearance or even worsening of previous problems. So moving on to discuss the treatments for PTSD and also the clinical practice guidelines. Now, I realise that some people here might not be aware of what clinical practice guidelines are, so I thought I'd just give a very quick outline of what they actually are. So basically, guidelines are designed to guide appropriate treatments in the context of each person's unique circumstances and their overall mental health care needs. Of course, it doesn't need to be mental health care needs. We have guidelines in all sorts of health contexts. First, though, a couple of observations about clinical practice guidelines. So they're based on a systematic review of the available evidence. So that's the available evidence. So it's pretty important they're not necessarily covering everything because there might not be evidence on some treatments. And if we don't have evidence on treatments, they don't make their way into the guidelines. Secondly, guidelines don't substitute for the knowledge and skill of competent individual practitioners. And it's also important that practitioners are able to interpret and implement treatment recommendations in the context of good clinical practice. So coming to the Australian guidelines for the prevention and treatment of acute stress disorder, post-traumatic stress disorder and complex PTSD, it's a bit of a mouthful. So let's just call them the PTSD guidelines, and they provide treatment recommendations reflecting current evidence on how to better understand or better respond to the needs and preferences of people living with these mental health issues. They're intended to guide the care of all Australians who've been impacted by trauma. They cover children, adolescents, adults, and even older adults. And guidelines cover recommendations for acute stress disorder as well as for PTSD. Just a little bit of, well, an update about, well, not an update, what is acute stress disorder? We don't talk about that so much. Most of the symptoms of acute stress disorder and PTSD are the same. It's just called acute stress disorder in the first month, and it's called PTSD after that. So from now on in, I'll just refer to PTSD. You'll see that the guidelines also cover complex PTSD, but however, as the systematic review of the evidence didn't find any current evidence base for the treatment of complex PTSD, we don't have any treatment recommendations in the guidelines, and I won't be speaking about the treatment for complex PTSD today. The guidelines cover recommendations for prevention through to early intervention, and also, of course, treatment of PTSD. They're intended to be used by practitioners, by their clients, by their patients, by people with lived experience of trauma, by service planners, by service funders, and by insurers. They've been approved by the peak health research body, the National Health and Medical Research Council, or you've probably heard of the NHMRC, and they've been endorsed by the peak professional organisations. So the APS, or the Australian Psychologist Society, the peak body for psychiatry, and also the peak body for general practice, or GPs. So a quick timeline of what the PTSD guidelines have looked like. You can see here their history. The first version was approved in 2007, and then in 2013, the second version was expanded in scope to include children and adolescents. And in 2019 to 20, which is when I became involved, the guidelines were substantially revised again and included the new diagnosis of complex PTSD. So the most recent updates were approved at the end of last year, so that's December 2021, as part of the continual review process. In improving those recommendations, the NHMRC considers that they meet the NHMRC standard for clinical practice guidelines, which is a fairly high bar, and each approval is valid for a period of 5 years. So guidelines 2020, the most recent guidelines, in the last 2 years, the format of the guidelines changed. First of all, we moved to a living guidelines model. So that means that these guidelines are now under continual review and updating of the recommendations in response to new evidence. That ensures that guideline recommendations are always current, they're always valid, and that they're a source of timely and trustworthy advice to clinicians and other people who are using the guidelines. Second change for these 2021 guidelines was that we started using the Magic App platform. So we've retained the supporting chapters on the Phoenix Australia website, as we're aware that we get a lot of downloads of those chapters indicating that they're widely used. However, all the technical information about the evidence which underlines the recommendations made in the guidelines is located on the Magic App platform. So what do the treatment recommendations look like in the guidelines? Basically, there are recommendations made either for or against a treatment option. I'm just going to see if I can get my little laser pointer happening here. So you can see here that we can have a strong recommendation either for a treatment recommendation or a strong recommendation against a particular treatment. A strong recommendation means that all clinicians should provide the intervention, if it's for an intervention, to all or almost all people in all or almost all circumstances. A conditional recommendation, we can say we can have again a conditional recommendation for a treatment or a conditional recommendation against a treatment. Clinicians should provide the intervention to most people, but not everyone. It will depend a little bit on the circumstances of the case and also whether a strongly recommended treatment is available. We also have research recommendations, and research recommendations are made for those treatment interventions that are considered promising on the basis of preliminary evidence. They warrant further research. They're not strong enough yet to be a treatment recommendation. Okay. So, oh, now I can't change because of the pointer, I think. So what are the key treatment recommendations? So first of all, just after someone has been exposed to a traumatic event or a potentially traumatic event for them, what's the recommendation for treatment? So what we have here is actually a recommendation against a particular treatment. And we have a recommendation against a treatment called psychological debriefing. So in psychological debriefing, shortly after the traumatic event, people are asked to provide detailed facts about their traumatic experience, their thoughts, their reactions, their symptoms, before being provided with psychoeducation about symptoms and how to deal with them. So just to reiterate, that's actually a recommendation against psychological debriefing. Instead, in the first few days or weeks after a traumatic event, practical information and support might be all you or your client needs. These are actions consistent with psychological first aid or PFA, which is a simple and practical approach that anyone with the appropriate training can use to help calm a person in distress and support their recovery. So people cope with the impact of the traumatic event in their own individual way. In the first days and weeks following a traumatic experience, it's important that the person is supported in doing what helps them get through that experience. For some people, that might involve talking about what happened to a person or a professional that they trust. For other people, it might mean spending time with friends and not really focusing on what happened. If the person's very distressed or feels they're not improving after 2 weeks, we suggest seeking advice from a health practitioner. And of course, your GP is a really good place to start. So what next? We've just talked about what's the recommended intervention straight after someone's experienced a traumatic event. And I should just mention we're talking about adults here. So what about within the first few months of a traumatic event? When the person's showing some symptoms of PTSD perhaps, but they don't have a full diagnosis of PTSD, the strongly recommended treatment then is a stepped care approach. So the stepped care approach involves ongoing monitoring of people who are more distressed and or at a heightened risk of poor psychological adjustment, with increasingly intensive interventions delivered as indicated. Treatments are generally CBT-based. They're sometimes based on other psychological approaches, such as motivational interviewing, and they might include components of case management and prescription of medication. In addition, in the first few months after the experience of trauma, there's a couple of conditional recommendations made for adults, being, first of all, trauma-focused cognitive behavioural therapy or trauma-focused CBT, and it's recommended in preference to doing nothing or administering no treatment. And there's also a conditional recommendation for brief EMDR. Again, that's in preference to doing nothing. So what about treatments for adults when they've been diagnosed with PTSD? So you can see on this slide here the first line treatments that are recommended, and there's 5 types of psychological therapies recommended here. So they're trauma-focused CBT, prolonged exposure, cognitive processing therapy, trauma-focused cognitive therapy, and eye movement and desensitization reprocessing or EMDR. It's a really strong body of evidence for these recommendations. I think there's over 230 high-quality studies that lie behind these recommendations. I'm not going to go into what each of these therapies are. On the Phoenix Australia Guidelines website, we've got a really useful summary sheet that explains in more detail what each of those psychological treatments look like. And I'd recommend having a look at that if you've got interest in finding out a bit more about each of them. Rather than going into detail about each of them, I thought that it might be helpful to highlight the core elements of each of those recommended psychological therapies or psychological treatments. So first of all, they help the person confront their memories in a gradual, safe, and supportive manner. They also assist the person to gradually confront places and activities they might be avoiding, and avoiding is a really big issue in PTSD. People feel quite fearful of many varied situations or events or memories, and understandably go out of their way to avoid them. But this means that they can't engage with their lives. So addressing that avoidance is really important for reclaiming your life after PTSD. And the third core element of those therapies is that they assist the person to address the thoughts and interpretations that might be blocking their recovery. thoughts and interpretations about what happened during the trauma, what it means about themselves, what it means about other people. There's often a distrust of other people, and what it means about the world. Now, still talking about treatments for adults with PTSD, the second line treatments with a conditional recommendation are recommended when the strong treatment recommendations that I've just spoken about, usually the trauma-focused cognitive behavioural therapies or EMDR, are not available or they're not acceptable to the person receiving the treatment. Again, some of these treatments might be quite familiar to you. They're explained more in the chapter on our website that summarises interventions, and they're also in the Magic App platform. In the 2021 guidelines, we updated with a new category on treatment delivery modalities. So for adults with PTSD, the recommendation, and it's a conditional recommendation, is to offer trauma-focused CBT delivered via telehealth. And so alternative treatment modalities like telehealth, they help overcome the barriers to treatment that some people have, including distance or travel time, cost, privacy considerations, a lack of mental health providers in the area, and perhaps perceived stigma of undertaking the therapy in person. So as for the other conditional recommendations here, telehealth is recommended when the face-to-face trauma-focused cognitive behavioural therapies, or EMDR, are not available or not acceptable to the person. So what about medication for adults with PTSD? As you now know, the recommended first-line treatments for adults with PTSD are trauma-focused psychological therapies. The pharmacological option or medication is considered a second-line option. So the types of medication offered to treat PTSD are usually antidepressants. Even if you don't have depression, antidepressants can help make the feelings associated with trauma more manageable. There are 4 antidepressants which have the strongest evidence base for treating PTSD in adults. These are the 3 selective serotonin reuptake inhibitors, that's otherwise known as SSRIs, that's paroxetine, fluoxetine, and sertraline, and also one SNRI, or a serotonin noradrenaline reuptake inhibitor, which is venlafaxine. Now, for children and adolescents, there are no medication recommendations made for the treatment of PTSD. Where the health professional considers that medication is indicated, we suggest following the depression guidelines, which for children who are aged 12 to 18 years is fluoxetine. In reality, in clinical practice, medication is often the first and sometimes the only treatment offered for PTSD in adults. So the guidelines suggest medication where trauma-focused cognitive CBT is not available, not readily accessible, and not acceptable. Also in these following situations where the person might have a comorbid condition, so there's another health condition or mental health condition going on, and the associated symptoms mean that SSRIs are indicated. There might be other situations where, for example, the person's circumstances aren't sufficiently stable to commence recommended psychological therapy. That might be in a family violence context, for example, or perhaps the person hasn't gained significant benefit from previous psychological therapy, and so they're wanting to try something different. And of course, there might be a significant wait time before psychological treatment is available. That's been particularly the case over the last few years with COVID. And that means that medication might be considered. Now, I've spoken about the recommended treatments for adults. I'd now like to talk a little bit about the recommended treatments for kids. Now, I've mentioned already that there are no recommendations made in the guidelines for medication for children. As for adults, within the first 3 months of exposure to trauma, there's a conditional recommendation against psychological debriefing. So in that context, again, we'd be looking at psychological first aid or PFA. Within the first 3 months of the exposure to trauma, there's a recommendation for child and family traumatic stress intervention. That's an intervention or a treatment which emphasises family support and coping skills. For children and adolescents who are diagnosed with PTSD, there's a strong recommendation, as there is for adults, for trauma-focused CBT. That's either delivered to the child or perhaps delivered to the child with the caregiver present, if that's appropriate. There's also a conditional recommendation for EMDR for children. Here's a nice summary infographic of all the adult treatment recommendations. For adults, the main changes since the 2013 update, and that was the last major update we did before we moved to this living guidelines model. So the main changes are, there's a new strong, let me see if I can get my laser pen working again. So there's a new strong recommendation for the use of the stepped collaborative care model. So that's, I've mentioned that previously. So that's in the first 3 months after exposure to trauma. There's a new conditional recommendation for EMDR within the first 3 months of the traumatic event. So that's what we've got there, conditional recommendation. And the broad category of trauma-focused CBT has been divided into variants. So they were the strong psychological treatment recommendations I went through previously. So that's cognitive processing therapy, cognitive therapy, prolonged exposure, as well as EMDR. We've got new conditional recommendations for specific populations, for example, narrative exposure therapy. Initially, it's been broadened since, but it was introduced as a treatment for refugee populations. And we've also got new conditional recommendations for when trauma-focused CBT or EMDR are not available or not acceptable to the person receiving treatment. So these are group trauma-focused CBT, present-centered therapy, guided internet-based trauma-focused CBT, and stress inoculation training. And finally, there are some new categories that I've mentioned already. So there was the treatment modality category, which is, so we've got trauma-focused CBT delivered via telehealth. And we also introduced a comorbid category. So when a person has, say, an alcohol use or substance use, which is comorbid, which just means occurs at the same time as their PTSD, we've got some conditional recommendations for trauma-focused CBT. And if trauma-focused CBT isn't available, there's also evidence for non-trauma-focused CBT. And doesn't like me moving slides when I use that pointer. Here we can see the equivalent infographic of summary of recommended treatments for children and adolescents. And the main changes to the treatment recommendations since 2013 are an increase to a strong recommendation for trauma-focused CBT for children with PTSD. And we've got that new strong recommendation that I mentioned before for trauma-focused CBT with a caregiver and the child, if that's appropriate. Also, the new conditional recommendation in the first 3 months after exposure to the trauma for the child and family traumatic stress intervention, and a new conditional recommendation for EMDR. That's recommended when the strong recommendation, which is trauma-focused CBT, is unavailable or unacceptable to the person who's going to have the treatment. So coming towards the end of my presentation now, I've got a few key sort of takeaway points here. First of all, I really wanted to emphasise that trauma is common and that most people recover from it, either without assistance or with some support and treatment. First, after trauma, most important thing is to get practical support, supply people with information, and just, provide support. The evidence-informed sort of model of psychological first aid there is quite relevant. In terms of treatment for trauma, a lot of trauma treatment involves confronting memories and beliefs, and medication may help in some circumstances. It's never too late to start treatment for PTSD, irrespective of how long ago the exposure to the trauma was. And for people who are looking for treatment, just as a clinical psychologist, I always say it's your treatment. It's okay to ask questions. It's okay to go and do your research. But of course, your GP is a good place to start. You can find lots of useful information and resources on the Phoenix Australia PTSD Guidelines website. I've just given you a screenshot here of these are all the titles of downloadable supporting chapters which support the use of the treatment guidelines. There's a couple of really useful chapters. Well, I think actually all the chapters are really useful depending on your interest areas. But I think a lot of people look at chapter 4, which is a summary of all the different interventions, and chapter 6, which contains all of the treatment recommendations. We've also got some really useful summary documents on our website, and yeah, I'd really recommend going there. They're for clinicians, they're for people with lived experience of trauma, for carers, for caregivers, for parents. And we're really open to providing other groups with resources if you let us know what your needs are.